Thank you for this privileged invitation to the 68th Annual Conference of the Indian Association of Cardiovascular and Thoracic Surgeons. It is my prime clinical duty to highlight the prevention of avoidable hospital-associated venous thromboembolism in every patient and all the time. We now are very well aware that hospital-associated venous thromboembolism is a leading cause of premature deaths worldwide. Sadly, hospital-associated venous thromboembolism accounts for more than half of all venous thromboembolism. Interestingly, this can be prevented in over 70% of patients, but tragically, less than half of hospitalized patients receive any form of appropriate prevention globally. Thus, it is the responsibility of every healthcare worker to prevent venous thromboembolism in hospitals. Clinical leaders in the country highlight the fact that the prevention of VTE in hospitalized patients is the number one patient safety measure in India. How do we achieve this? In practice, this requires a complete 360-degree re-engineering of our hospital professional ecosystem. This starts very simply by recruiting top-level clinical and administrative commitment. This should lead to a mandate of an universal institutional VTE prevention policy, enabled both by regulatory commitments as well as by accreditation mandate. This should be followed by administrative measures by the institution of a HAVT prevention committee or group and the creation of an institutional policy and protocol document to prevent HAVTE. The absolute universal mandate to include the prevention of HAVT in routine clinical decision making is absolutely necessary. One must also aim for cultural change in the hospital by including in educational and training initiatives in the hospital the prevention of VTE, as well as including this in internal CME processes, as well as screening and surveying for hospital-associated venous thromboembolism and providing the feedback also through periodic audit to the clinical divisions. At our institution, we made a start years ago, building up from what individual departments were doing to creating a singular hospital or institutional hospital-associated venous thromboembolism prevention initiative. This began by gathering a group of committed clinicians and nursing staff and setting forth a policy and protocol document which outlined the clinical pathway, beginning by risk assessment for thrombosis and bleeding, the creation of an order set, the implementation of a VTE prevention care bundle, followed up by surveillance and audit processes. Of note, we have a very clear algorithm to help clinicians prevent venous thromboembolism in hospitalized patients, beginning by ruling in or out pre-existing venous thromboembolism, and in the absence of which a thrombotic and bleeding risk is carried out. This is combined to create an order set, and this is then executed by the staff and nursing personnel. We have been very objective at every stage, starting in the process of clarifying the presence or absence of pre-existing VTE by outlining a clinical objective evaluation of our patients by using the Wells score for DVT as well as for pulmonary embolism, overlaid by, if necessary, a clinical consultation by a vascular physician or by focused investigation. Once the stage is through, we risk assess for thrombosis in surgical patients, for instance, using the Caprini risk assessment model. Once clinical data is available, the calculation of the Caprini VTE risk score takes under 2 minutes for even a nurse. A bleeding risk assessment is done using a list provided by Bell et al., and this also includes leeway times for anesthesia and surgical interventions. Using a combination of both the thrombotic and bleeding risk assessment, we create an order set for preventing VTE in the given patient, which is vetted and then attested by the admitting consultant, or in an emergency by the admitting resident in consultation with the consultant. We're also in the process of creating public and patient awareness media and brochures to help recruit patient and family cooperation and compliance with VTE preventive strategies in the hospital and post-discharge. Finally, we capture compliance data through our VTE Care Bundle checklist. This data is planned to be plowed back through the feedback loop to benchmark our outcomes. Already, VTE prevention awareness and training initiatives are in place amongst the nurses and doctors. And despite the slowdown by the COVID pandemic, we hope to accelerate this in the coming years. We've been instrumental and fortunate to have been involved in certain international and national publications for venous thromboembolic related data and evidence in our clinical care. We've also led through 4 national conferences, leading finally to the inclusion of the prevention of hospital-associated venous thromboembolism in the National Patient Safety Implementation Framework 2018-2025. The operational guidelines of which are awaited shortly, and this hopes to include in the surgical safety checklist the capturing of data relating to the implementation of VTE preventive strategies in surgical patients during hospitalization. Thank you very much for a patient listening.